Greetings, I am Dr. Kim Young-won of Online Surgery. I am honored to discuss about surgery with you today. Let's look at the panoramic image. 51-year-old male patient. The patient does not have any special systemic disease. At the time of patient visit, due to secondary caries in the posterior bridge, which was made in the past, there was pain and discomfort. As you can see on the apical side of number 7, there's wisdom tooth, which is impacted deeply. On the panoramic image, number 7 and number 8 are quite close, and the impacted wisdom tooth is quite close to the nerve. It's almost as if it's surrounding it. I looked at CT 6, which has been missing for a significant period of time. Compared with lingual, the buccal side of the cortical bone is quite thin, and bone quality is not very good because it has not been functioning. In the case of number 7, around number 7, the alveolar bone is not very good. There's a lot of destruction on CT. Number 7 and 8 are not in contact. When I looked further into this matter, the root of number 7 is towards the lingual, and the head of wisdom tooth is towards the buccal. On the panoramic image, it looked as if they were in contact. However, there's no direct contact. On CT, I looked at the root of the wisdom tooth. As you can see, as shown, bifurcation can be observed at the root, and the inferior alveolar nerve is slightly misformed. If I were to extract number 8, it is going to be very difficult to do so, and there's high possibility of inferior alveolar nerve damage. Considering the patient's age, in practical terms, if you want to extract wisdom tooth that has been impacted as deep like this, and if the canal is slightly misformed as the root comes out, there's high possibility that pressure will be applied after extraction. Nerve damage can occur with high possibility. Therefore, number 8 was decided to be left untouched. As you can see, when you remove the bridge, the number 5, you just need to do crown once again. In the case of number 7, there's secondary caries and the condition is very poor. Therefore, extraction was decided. After extraction, number 5, new crown was provided. Number 6 and 7. You can see the extraction socket here. The wisdom tooth is over here. The plan is to place 2 implants regardless of the wisdom tooth. OneGuide was used and digital guide was to be used for implant placement. Surgical report is as shown. In the case of number 36, TSⅢ 5.0 by 10 mm was planned, and the distance with inferior alveolar nerve was okay. In the case of number 37, KSⅢ was chosen to be placed. 5.0 by 8.5 was to be placed. When we formed the plan, it was before extraction. Actually, the root of number 7 is slightly exposed in the distal side. Therefore, if necessary, bone graft will be done during surgery. TSⅢ and KSⅢ. I wanted to do clinical comparison, and with patient's consent, I decided to place TSⅢ on the mesial one, and in number 37, I plan to place KSⅢ. The drill sequence is as shown. For initial drill, 3.5 is going to be used, and for final drill, 5.0. I believe we won't face any major issues with this. This was how anticipation was done on the extraction socket. The distal side, in number 37, the thread is slightly going to be exposed. Because it's an extraction socket, you could just leave it as is, but I plan for bone graft. This is post-op. You can see that the internal screw size is different between the two. TSⅢ 5.0 by 10 millimeter and KSⅢ 5.0 by 8.5 millimeter were placed. On the extraction site, on the distal side, granulation tissue was removed. Sure os bone graft was used. Post-op image. If you look at the CT image as planned, implant has been placed in the planned position. This is number 36, and in number 37, implant has been placed in the desired position, and distal to implant in the number 37, allograft was used. The sure os was used for bone graft. As shown on CT number 8 was not directly related. It is fully impacted. Therefore, extraction was not done. As planned, implants were placed in the desired position. In number 36, implant has been placed TSⅢ, 5.0 by 10 millimeter, and in number 37, 5.0 by 8.5 millimeter KSⅢ implant was placed and bone graft was done on the distal side. Let's look at the video clip. As you can see, OneGuide surgical template has been adapted to check whether it fits well. Mirror is being used to see if it fits with the adjacent teeth. Tissue punch is used to punch the gingiva. Template is removed. Soft tissue is fully removed and checked. Once again, template is adapted. Initial drill is used for drilling. In number 36, 3.5 by 10 millimeter OneGuide drill is used. This is a wide hole. You can see that there's gold coating. 5.0 by 10 millimeter OneGuide drill is used. Next, the TSⅢ 5.0 is used. This is BA surface, hydrophilic surface. You irrigate it sufficiently before implant placement. The engine is used to place it about 80%, and then torque wrench is used to find the correct position. In this case, I didn't do it this time around because we're taking film, but if you put your finger and press it, you'll be able to get implant position in a more stable manner. In number 37, initial drilling is done. Although it is posterior area, the patient can open mouth well, so closed type stent was made. Closed type is better than open sleeve type. 3.5 by 8.5 OneGuide drill is used. Next, 5.0 by 8.5 is used for drilling. Next, KSⅢ, 5.0 by 8.5 millimeter implant is used. Sufficient irrigation is done. Implant is being positioned. Implant is placed about 80% with engine, and implant driver is used for final depth adjustment. Primary stability is good. Smart peg is connected. ISQ value is measured. In the case of number 36, ISQ is approximately 74. And for number 37, it's 70. As mentioned earlier, the distal side of the extraction socket, the thread was slightly exposed. Incision was made to do GBR, and granulation tissue on the superior side is removed. Cover screw is connected first. Distal to the implant, you can see that there's a slight thread exposure. Freeze-dried allogenic bone. Sure os pen type is used for bone graft. I'm slightly adding more. Superior to that, I'm doing bone graft sufficiently. On the extraction socket, the gingiva is slightly less healed. OSSTEM is used to cover that area. I use one layer here. Bone graft, it's not extensive, therefore OSSTEM is sufficient. I use 2 layers and do suture. I use 2 layers of OSSTEM. Suturing is done in a hidden X method, from mesial to distal, and from buccal to distal, and then to lingual mesial. Unlike the extraction socket, hidden X suture is used to fixate the membrane. You can see that where the soft tissue is lacking, collagen membrane is compensating for that. That's how surgery was completed. This was a simple case. The distal side, I used a KS implant, the same diameter implants were used. In the mesial side, TS 5.0 by 10 millimeter was used, and the distal one was KS3 5 by 8.5 millimeter implant. I wanted to look at the long-term results, and I wanted to check the stability and safety. I used a TS3 in the mesial side, and in the most posterior area, KS3 was used to do long-term clinical follow-up. Thank you for watching.